As I mentioned in previous talk that not all the patients in ICU are the same. And you can figure out that not all the Candida isolated from different sites are same significant. How about the Candida isolated from intra-abdominal specimen? An innocent bystander, or because Candida is a normal flora, so it might be just an innocent bystander. And unlike Candidemia, isolate of Candida in this specimen is not anonymous with the need of antifungal therapy, as mentioned in previous speaker. However, the differentiation between colonization and infection are very difficult. In alternative scenario, the isolation of Candida are very important, as intra-abdominal infection are common surgical emergency and has been reported as major contribution to non-trauma death in emergency department worldwide. And the cornerstone of effective treatment are early recognition. In addition, adequate source control and appropriate antimicrobial therapy. So I was talking about these three perspectives. According to a very large-scale worldwide study, they emphasize that the source of infection of this intra-abdomen vary from different appendicitis, cholecystitis, and etc., trauma or perforation. And the intra-abdomen candidiasis is the second most common form of invasive candidiasis after candidemia. It includes intra-abdominal abscess, secondary peritonitis after repeated leak, infected pancreatic necrosis, cholecystitis or cholangitis, or primary peritonitis. Unfortunately, blood culture have very poor sensitivity as Candida is rapidly clear from the blood. Take a close look from Professor Chapakati's study. You can see the Candida in acute pancreatitis. It is among 300 patients, 41 patients have invasive candidiasis. They are true or possible. True means that the Candida was isolated from pancreas tissue. For those culture is isolated from the drain fluid influence without Candida isolated from the operated sample as a possible cases. However, there are additional 19 cases with candidemia in this patient cohort. And this kind of patient, Candida albicans, not number one. Candida tropicalis are number one in this India cohort. Patients with candidiasis, they are associated with more severity of pancreatitis, more likely receive total parenteral nutrition, need more surgical intervention, sepsis, and fluconal prophylaxis. These patients were associated with longer hospital stay and mortality. So this is really an important issue. As we mentioned, the culture has a limitation, so we need non-culture-based methodology, including Manon, germ-tube, beta-D-glucan PCR, and et cetera. According to a serious study that you can see different methodology was associated with different sensitivity or specificity. You can see that not satisfied, even non-culture rapid method, and the specificity are not perfect as well. Also, beta-D-glucan. More important, it's not available in the majority of households in Asia country. Also, PCR. In addition, how to interpret this non-culture test result, no matter how sensitive or specific or culture method may be, Clinicians must accept a level of uncertainty when interpreting this result because predictive values are dependent on sensitivity, specificity, and the pretest likelihood of invasive candidiasis. However, if physicians are not aware of what kind of patients are at risk, they test widely, then the pretest likelihood are very low. Then how to interpret it will be very difficult. So you need to aware the disease prevalence in various clinical settings in your patient population and how to implement this kind of test. In most settings, the positive predictive value of these tests are low, but negative predictive value are high. For tests to be useful, clinicians must understand the pretest likelihood of invasive candidiasis in addition to the test performance for the most common disease manufactured in a given patient. In addition, Candida are not the same. Not just the size of the specimen are not the same. The Candida species are not the same according to pathogenesis. For example, this intra-abdominal infection, they very commonly is polymicrobial. And based on this mouse model, they show that for Candida albicans, infection with Staph aureus is associated with higher mortality than other Candida species. For example, Candida glabrata. So when we interpret the risk, we take into consider many factors. Overall, we need to early recognition because the occurrence of Candida super infection in patients with prior sepsis or bacterial infection, they might associate with blunted immune response. So clinicians need to be very aware, alert. In addition, because in the presence of polymicrobial infection, sometimes we are neglect the presence and the significance of Candida isolate from this kind of specimen. In addition, we need to be alert the possible presence of intra-abdominal pathological change, such as perforation, tumor, or fistula formation. Therefore, we need to incorporate some inflammation marker to help us to guide whether they have infection or not. For example, C-reactive protein or procalcitonin. However, data are limited. This is very important for fungal peritonitis. The ascites demonstrate very high level of aminase. It's a very rare manifestation of gastric perforation. Otherwise, it's very difficult to control intra-abdominal infection due to Candida. Therefore, early source control as well as antifungal therapy are important. Not just a bacteria, we need to distinguish whether Candida are important. In addition, we need to identify the source and intervene properly. Therefore, this is a very, for host, it's younger or absence and early source control are independent predictor of survival. Therefore, sometimes we need to consult ID physician to help to guide the most aggressive and appropriate therapy. Overall, the recommendation on the management of intra-abdominal candidiasis include aggressive diagnosis. No matter how conventional, this is very feasible direct microscope examination to identify yeast in the specimen. It is very important. For those very high risk of invasive candidiasis, we can implement prophylaxis strategy or empirical antifungal therapy using the proper antifungal agent. Or we can incorporate biomarker to guide us to distinguish it's only colonizer or need to start preemptive therapy or empirical therapy. Among various antifungal, fluconazole can be adopted for the empirical or targeted therapy for non-critical ill without previous exposure to azo, unless they are known to be colonized with a Candida strain with reduced susceptibility to azo. In addition, treatment can be simplified by step down to an azo after several days of therapy using more expensive cyto drugs such as echinocandin or liposomal amphotericin B if the species is susceptible and the patient is clinical improvement. So incorporate this recommendation, we can take a look at this treatment algorithm. For high-risk patients, we incorporate one or more clinical prediction rule, incorporate some biomarker to guide us initiate antifungal therapy or only source control or both. And the antifungal therapy, you can use azo, echinocandin, or amphotericin B regimen. For those confirmed, then we can step down to target therapy. In conclusion, Candida species are part of our human flora. However, in selected conditions, it can cause intra-abdominal candidiasis in patients with impaired systemic or local immunity. It consists of a diversity of disease and associated with heterogeneous manifestation, which may result in poor outcome. It highlights the importance of careful clinical evaluation and a multidisciplinary approach in this kind of high-risk population, including diagnosis during operation, plus some biomarker, identify and control the source, aggressive antifungal therapy when indicated. Of course, the role of ID physician may contribute as well. Thank you for your attention.